Good morning to all of you. Happy morning. I'm very glad to attend this session. Actually, I would like to thank all the participants who have come over here to attend and get benefited. And it's my pleasure to be here to introduce our speaker, Dr. S.P. Kalantri. And Dr. S.P. Kalantri, MD, MPH, is a Director Professor of Medicine at MGIMS and Medical Superintendent of Kasturba Hospital. He obtained MD from Government Medical College in 1981 and joined MGIMS immediately. In 2004, he won Fogatti AIDS International Scholarship and obtained MPH from the School of Public Health, University of California and Berkeley. At MGIMS, Dr. Kalantri heads an internal medicine unit, teaches medical students and residents, conducts clinical research, and manages the hospital. He successfully campaigned against sponsorship of medical conferences by drug industry and introduced low-cost drugs in the hospital. He also helped the hospital build a hospital information system that has improved the quality and management of clinical care. And more recently, he started a palliative care unit in the hospital. Dr. Kalantri edited MFC Bulletin 1989 to 92 and was an associate editor of Indian Journal of Medical Ethics in the year 2001 to 2004. And his general interests include evidence-based medicine, medical ethics, public health, and information technology. He reviews the manuscripts for major medical journals regularly. And coming to the education, he has completed his MBBS in the Nagpur University in the year 1977 and MD in the year 1981 in the same Nagpur, and MPH from the University of California in the year 2005 under the epidemiology division. And coming to his positions and the employment, and he has been a medical superintendent from 2009 till date in Mahatma Gandhi Institute of Medical Sciences, Sevagram. And coming to the publications, he has more than 150 to 160 good publications, and his profile is well elaborated, and he has wide experience in this particular field. Actually, I would like to invite him and thank him for taking up his valuable time and attending this session. Thank you, sir, once again for coming over to this place and give your valuable input. Actually.
So thank you, sir, for your kind introduction, and thanks, Anand and your team for having me here. It's an honor and it's a privilege here. So over the next 20 minutes or so, I would be talking about MGIMS Sevagram's experience in introducing affordable medicine to the common public. And being a physician, I would start with certain case scenarios, isn't it? And these are the cases that we see in our IPDs, OPDs, ICUs, cath labs, in operation theaters almost day in and day out. So you happen to see a 40-year-old woman who has hypertension, who has type 2 diabetes mellitus, who had an MI in the past, and who also has heart failure. Then you are called to see a 16-year-old girl whose appendix perforated. She has perforation peritonitis, and she gets into a medicine ICU, and she is battling for her life. She requires 2 drugs, antibiotics, at least piperacillin tazobactam and vancomycin. And then you see a 45-year-old woman in OBGY unit who had a relapse of her ovarian cancer. And now she requires at least 3 anti-cancer drugs to bail her out. And these 3 drugs are bevacizumab, carboplatin, and gemcitabine, very expensive drugs. And this is something that we see day in and day out, patients with chronic kidney disease who are anemic, laboring with hemoglobins of 6 and 7 grams per deciliter and requiring twice a week shots of erythropoietin. And lastly, we have a 45-year-old woman who has severe rheumatoid arthritis. The traditional therapies have failed her, and now she badly needs newer biosimilars and very expensive drugs to make sure that she is able to complete her activities of daily living and leads a very independent life on her own terms. The common thread that runs through all these 5 case scenarios is that all of these illnesses are pretty common, and all of these illnesses require drugs that are extremely expensive. For example, in the first scenario, this patient would be on as many as at least 7 drugs: aspirin and clopidogrel for her 2 blood thinners, a statin for her coronary artery disease, a beta blocker, calcium antagonist and perhaps an ACE inhibitor, and metformin and glimepiride. So to be able to afford these drugs, 7 drugs for next 30 or 40 years becomes extremely difficult and challenging task for a physician to prescribe as well as patient to adhere to the treatment. And the same happens to the subsequent stories as well. So with the result that all these illnesses lead to a catastrophic healthcare expenses. Now, these numbers are a bit dated. They back to 2011, which said that 60 million Indians are pushed below poverty because they are not able to meet their healthcare costs. We also know that in 70% of the patients need to pay from their pocket when they get hospitalized, and more than 5% Indian households are pushed below the poverty line because of the catastrophic health expenses that they incur on hospitalization, their medical care, and drugs. So these are some of the healthcare expenses insights that even the government of India spends about 22% on buying drugs. That if you take at the average hospital cost across the country, an average hospitalization in a government hospital would cost about 5,000 rupees. In a private hospital, the cost is almost 8-fold. Of these, patient will have to pay about 2,000 rupees for the drug charges in a public hospital. But when it comes to a private hospital, the cost climb to almost 7,000. And only a third of patients in urban rural areas and a fourth of patients in urban areas are able to either access hospitalization or seek hospitalization in public settings. And only there's a 1 in 8 chance that a person living in a village or a small city would be able to receive free medications from the government or NGO. Now, given the fact that the public healthcare system in India is rapidly deteriorating, given the fact that most people are forced to buy drugs and something that they cannot afford, the scenario becomes very, very tragic, isn't it? Against this background, let me introduce to you the institute I come from. The institute is called Mahatma Gandhi Institute of Medical Sciences. And on the right side, you would see two very great people, Mahatma Gandhi with Dr. Sushila Nair. So Dr. Sushila Nair was the physician to Mahatma Gandhi. And as the story goes, that in 1938, when Mahatma Gandhi was returning from Kolkata, Dr. B.C. Roy had asked Dr. Sushila Nair to accompany Mahatma Gandhi because Mahatma Gandhi had a blood pressure of 230/120. And over the next 3 weeks, now Sushila Nair in Sevagram, who was just a 24-year-old intern, now treated Mahatma Gandhi's blood pressure and monitored his blood pressure. Imagine a scenario, a 24-year-old intern taking care of probably the biggest person on the earth, Mother Earth at that time, and Mahatma Gandhi believing in her knowledge, in her diagnostic skills, and in her prescriptions. So over the years, this relationship grew, it took roots. And in 1964, Dr. Sushila Nair became the Union Health Minister. And in 1969, she founded Mahatma Gandhi Institute of Medical Sciences in a very small village called Sevagram. I looked at the history of Dr. Sushila Nair and was amazed to find out that in 1938, she graduated from Lady Hardinge Medical College, Delhi. That was a time when India had only 10 medical colleges, and these 10 medical colleges put together would admit 600 medical students countrywide. And Lady Hardinge Medical College, Delhi would admit only 25 students, and Sushila Nair had only 3 women in her class. So of the 600 medical students who graduated in 1938, there were only 51 women there, telling us about the stark male to female ratio in medical education at the time. And Sushila Nair, now over the next subsequent decades, became a beacon of inspiration and hope for a large rural masses. So she founded this medical college in 1969. Our college is partly funded by state government and partly by the central government. And it's not for profit organization. So we admit about 100 medical students every year. Like CMC Vellore, we also lost a case in Supreme Court where we're trying to retain our own admission rules. So since 2016, we are no longer to have our own admission policy, but every year we admit close to, take care of close to 800,000 outpatients and admit about 50,000 inpatients. We deliver about 6,000 women every year. And most of the people who seek healthcare in Sevagram come from neighboring districts, and most of them are either poor or belong to the lower socio-economic strata. So between 2000, 2010, after Dr. Sushil Nair passed away, Sevagram took some momentous decision, and Dr. Sushil Nair should have been extremely proud of these decisions, which unfortunately could not be taken when she was alive. So in 2002, MGIMS Sevagram became one of the few medical schools in the country which completely denied sponsorship from pharma industry, either directly or indirectly, for all its academic activities. And we have shown in the last 20 years that good academic activities can be conducted in a medical college, provided we keep them modest, provided we keep them simple, and provided we keep them absolutely academic. And we have been extremely proud that we have been able to conduct pharma academic activities in Sevagram with absolutely zero pharma support, either directly or indirectly. In 2009, some of us thought that it is shameful for the medical students to be briefed, bribed, and biased by medical representatives in a teaching medical college, isn't it? And therefore, we banned the entry of medical representatives in Sevagram across the campus. And a year later, concerned that the healthcare costs are catastrophic, most of our patients are not able to afford the cost. And to be honest, I must admit my ignorance that at that time, I was also one of those hundreds and thousands of physicians who took pride in writing those brand leaders in the market. So for me, ciprofloxacin was Cifran, and ibuprofen was Brufen, and diclofenac was Voveran, and so on, not realizing that the brand leaders are the costliest drugs here. And so we introduced what is called a low-cost drug initiative in Sevagram. So it has been almost now 13 years that this low-cost drug initiative is running, and it is successfully running in Sevagram. So recently, last month, Neelakantan and Kulkarni, Neelakantan is a lawyer. They wrote a fantastic article in Indian Public Policy Review, and they said that people may choose to avoid going for treatment altogether if they are under the impression that the cost of treatment is likely to be prohibitively high. And this is something that we see all the time in Sevagram, that people with say a woman with ovarian cancer would drop out after the second cycle of chemotherapy because she cannot afford the third cycle, or the people with hypertension or diabetes mellitus would stop some of their drugs and then would stop them altogether because they find it very difficult to sustain this drug therapy all their life. So this is how we started the low-cost drug initiative. I will give you a brief preview of the process there. That every year we send a list of chosen drugs, isn't it? And these drugs are chosen based on clinicians' experiences, the maladies prevalent in Sevagram in that particular year, to all department heads and faculty members. And then these department heads and faculty members now carefully look at the drug list and edit the list there. And then we ask the pharmacy department to identify the common doses and stocking practices for these drugs. We ensure that the list is complete as much as is possible, and we avoid wastage there. And then based on our previous year's experiences, now we project the future volume and now start preparing for the tender. In this entire process, the hospital information system, which Sevagram designed in 2004 and has been running for the last 20 years, comes very handy because we are able to identify these lists, we are identified the volumes, the distribution of drug, our procurement, our stocks, our dispensing. Now almost everything in Sevagram is now computerized there. So the tender evaluation process goes something like this. Because we are government funded, partly government funded organization, we follow all the rules laid down by central government and state government. So we float tenders from 2016. We have been floating tenders on the Central Public Procurement Portal, and we have a 3-stage evaluation process. All the vendors are evaluated on the basis of pre-qualification criteria. There's a technical evaluation criteria, and finally there is a financial evaluation criteria. So in other words, we get to know that who are we buying these drugs from, what are their standing in the market, how long they have been active in the market, do they follow the GMP guidelines or not, and how much they are quoting. So based on this technical evaluation and financial evaluations, last year about 138 vendors countrywide participated in this tender process, and as the government rules have it, now we select the L1 there. So this table would give you an idea of the hospital statistics, the outpatients and inpatients I have already talked about. So our procurement budget. So MGIMS has a total budget of 240 crores per annum of which 70% goes to salary. Of the remaining 30% that we have, isn't it, last year 26.21 crore was allocated for buying drugs, chemicals, and diagnostic kits and surgical items there. And last year, we about 250,000 people now were able to fill their prescriptions from our own in-house pharmacy store. So roughly on tablets and capsules, we spend about 10 crores every year. Surgical items are the second on the list, about 7.38 crores per year. And the rest is distributed between implants, stents, syrups, ointments, eye drops, etc., diagnostic kits, etc. I looked at, before coming here, I looked at the top 10 drugs which are dispensed from our pharmacy, and I was slightly unpleasantly surprised many of these drugs here. For example, calcium and vitamin D tops the list there, and the second drug is pantoprazole, third is vitamin B complex. The drugs for lifestyle disorders, amlodipine, metformin, atorvastatin, and telmisartan come down, and then we have got paracetamol for people who have acute undifferentiated fevers, ferrous fumarate, and levocetirizine. And I also found a lot of irrational drugs also in the list, occupying 12th and 13th slot, like trypsin and antitrypsin, which the orthopedicians and surgeons routinely use, and several others, which I will not. So I asked some of my colleagues that why your pantoprazole has gone to number 2, and they said that they use pantoprazole and vitamin B complex not as an anti-ulcer drug or not to treat vitamin B deficiency, but they are placebos. So every person who comes in the OPD with some obscure abdominal pain ends up getting a pantoprazole, and vitamin B is complex. When you have nothing to prescribe, then you take the resort of vitamin B complex. The same thing happens with probably ferrous fumarate and levocetirizine there. So these next two slides would show you the cost differences. The first column lists the drugs, the second is the strength of the drugs and the price to the hospital. For example, we have been able to procure amlodipine, almost all these life-saving drugs, at less than 1 rupee per tablet. So amlodipine we are getting at 20 paisa, enalapril 50 paisa, telmisartan 78 paise, metformin 38, glimepiride 21. We add 20% administrative cost to our procurement cost. So the cost to the patient, for example, amlodipine is 24 paise, buy it at 20 paise, but the MRP which is written on this drug is rupees 250. Now, most of the corporate hospitals also do a similar process when they buy very low cost drugs, but then they do not pass on all the benefits to the patient. Instead, they sell on MRP, and this difference of 20 paise and 250 is now pocketed by several corporate hospitals and several NGOs as well. Several NGOs would justify, because otherwise where would the money to run an NGO would come from? So the money has to come from some sources there. So they often justify this thing. But it was a lesson. It was a big lesson for me when I got to know that the drugs are available, the quality drugs are available in India at a price that the patients can really afford. For example, injection, ceftriaxone, we are making available to the patient at 35 rupees per gram, meropenem at 330, vancomycin at 55, piperacillin, tazobactam 69, and so on. Erythropoietin, whose MRP is 1936, is available in the hospital at 171. Pralidoxim, palm, and anti-snake venom, which are huge problems in Sevagram, as Anand would know. Again, palm 1 gram injection is available at 29. Anti-snake venom, we are still buying expensive because there are very few agencies in the country which make anti-snake venom. So a day before, I calculated that if somebody has got hypertension, diabetes mellitus, hyperlipidemia, and coronary artery disease, and if this person is on as many as 7 drugs, how much would it cost per month? And the cost per month in our hospital is rupees 172 per month, which means just about rupees 6 per day, which means that you can have your diabetes, your hypertension, your coronary artery disease, and your hyperlipidemia treated at as low as rupees 6 per day. And we all know how much does it cost when we go to the private practitioners and in corporate hospitals. So the lesson that we learn is that it is able to fix the maladies in the public health by sticking to the basics, isn't it? By getting de-influence from pharma industry and making sure that we keep the best interest of the patient in our mind uppermost, and able to make sure that the drugs that they are getting are really cheap, they are really affordable. Now, Sevagram is not the only hospital in the country which does so. Tamil Nadu has been doing it for years together. Rajasthan has also been doing it for quite some time. The methodologies might differ, but the intention the same. But recently, I was attracted to read this paper from C.S. Pramesh, who is a thoracic surgeon and director of Tata Memorial Hospital, where he published his own experience that they have a national cancer grid where there are 250 cancer hospitals in the country. And Pramesh wondered whether these all 250 hospitals in the country can team together and do a kind of a group procurement. 23 of the hospitals agreed, the rest didn't because of several other reasons, isn't it? But when these 23 hospitals agreed and they procured 40 anti-cancer drugs for 23 national cancer grid centers, they found that the initial cost estimates were 15.6 billion at MRP. And what this consortium could get is that they were able to get these drugs at just 2 billion. So there was a 13.2 billion rupees saved. And the median saving was 82%, which ranged from 23% to 99%, the interquartile range there. And there was a huge saving so far as generics. I was so surprised that you are saving 99% on the cost of drugs. If all these parties now, if all these hospitals come together, join hands, iron down their individual differences and work for a common man, even probably the unaffordable cancer medicines would become affordable if the country does like this. So this Murali Neelakanthan and Ashish Kulkarni a fortnight ago published, eulogized this study and published and said that the time has come that in the entire country, especially in public health, we must float an idea of centralized procurement so that we will have that power of negotiation and we can negotiate really, really very, very hard. And if there is a uniform drug policy and uniform drug prescriptions all over the country, now this could be a utopian idea, may not be feasible. But if we really, if Pramesh and Tata Memorial have been able to do that in cancer, why shouldn't we be able to do it other disorders as well, in other settings as well? So they wrote that it's a simple and yet powerful idea that this kind of an intervention can reduce cost. We can use these funds in other health areas as well related to healthcare and ensure that the life-saving drugs and life-sustaining drugs are available in our hospital at a price that the patients can afford. Talking of pharma and medical profession, it always brings to my mind 5 Ps. So in the center, there is a very big pharma industry. The big pharma occupies the center stage. And this big pharma is controlling other 4 players. Now, who those 4 players are? Well, those players are the policy makers. I will take 5 minutes. Are policy makers, they are physicians, they are pharmacists, and they are patients, isn't it? And we know that directly and indirectly, we are controlled by our regulators, our governments, our pharmacists there, isn't it? But ultimately, the person who is most important, their patient, is always neglected or marginalized. So this is a paper from Prescribe International 2017, which shatters the myth that the big pharma is there to make innovative drugs and they act in the best interest of the patient, something in line with what Marcia Agnell wrote in 2004 in her famous book on drug industry, where she exposed that the big pharma is not meant to act for the common man, but it spends about 5 to 8 times on marketing than it does on innovating a drug. And they found that in the last 10 years, only 2 innovative drugs have come in the market. But the vast majority are either Me Too drugs, are of dubious value, are potentially harmful, or have been degraded further. So the claim by the big pharma that we are there to create innovative drugs for mankind is absolutely false, and it's a blatant lie. Coming to the Indian scenario, we have got as many as 60,000 brands in 6 therapeutic areas, and we have 3,000 pharmaceutical companies. There are 10,500 production plants, and the current worth of pharma industry, the best estimate is about 500,000 crores there. So one of the myths that I would like to shatter here is that almost 90 to 95% drugs that we are prescribing right now are not generic, but they are branded generic. For example, Crocin is a branded generic, Cifran is a branded generic, Voveran is a branded generic. So close to 90% of drugs that we are prescribing are branded generic, isn't it? And the innovative drugs are hardly less than 0.5%. The unbranded generics are also very few and are not always available in the market. So years back in 2007, this Nobojit Roy, Neha Madiwala, and Sanjay Pai did a fantastic study in which they interviewed the pharmacists, physicians, drug industry, and chemists, and they found out that the chemists and doctors conspire to make profits at the expense of consumers and public health, even as they negotiate with each other on their respective shares for the profit. So the three keywords here would be access, would be affordability, and would be quality. We are all too conscious of access to the healthcare. We are conscious of the fact that the drugs must be affordable, but sometimes we forget about the quality of the drug, which weighs very heavily in the minds of both patients as well as physicians. So what we need to do is that the brand leaders need not be the most need not guarantee your quality. That it's a belief which has got no scientific backing at all. And most of the off-patent branded drugs in India are produced by small companies and they are marketed by big companies. For example, we have got a place in Himachal Pradesh in the Solan district called Baddi, which is the hub of pharma industry. And the drugs are manufactured there and they are marketed by the big pharma industry. So I'm very conscious of this fantastic quote by the German pathologist Rudolf Virchow, who long back said that we the physicians are the natural attorneys of the poor, and the social problems should largely be solved by physicians, not politicians or not by economists there. So what should the regulators do? It is very simple. Their job is to protect the public and not pharma companies, isn't it? So they must be seen to act. They must be seen to be very, very proactive. They must be clear. They must be transparent. And there must be a lot of debate is generated in the Twitter these days about bioequivalence and bioavailability and stability and solubility. But we need to be on a single platform and need to be very clear about what all these issues are all about. Yeah. So this is what we normally teach to our interns and residents and young faculty members in Sevagram, that we must understand the complex interaction between pharma industry and the medical profession, that beyond medicine and beyond evidence, there is something called economics and ethics as well. And that they must be minimalist in their approach. They must subscribe to the policy of less is more. They must choose wisely about their drugs. And they must also recognize the hazards of overdiagnosis and overtreatments. If they stick to the simple basics, then probably they will be able to ensure that the drug therapies are really affordable to the patients. Yeah. We also teach them that there are many new products which are marketed very aggressively by pharma industry, but they offer absolutely no advantages over the traditional drugs. They are Me Too drugs, and they are sometimes potentially dangerous. Something that we saw in the COVID pandemic when we had several irrational drugs now being aggressively approved by CDisco and promoted in the market, and ultimately they all turn out to be very, very harmful. And lastly, the Me Too drugs as well. So a day before I read Dr. A.C. Anand's paper in National Medical Journal of India, where he was writing, just 2 minutes, that more than 15 drugs are available in India, and how do you choose a prescription? And most gastroenterologists in the audience said that, well, we will act in the best interest of a patient. We will choose 1 or 2 reputable drugs. And then he gave a list that there are 15 companies. Which of them is not reputable company? Now, how do you lay your hands on a particular drug? And the audience had absolutely no answer there. So finally, I'm paraphrasing Mahatma Gandhi here, and I'm replacing his word client and replacing it with patient. And I think that it's extremely pertinent that if we keep Mahatma Gandhi's quote in mind, whenever we see patients, whenever we treat their maladies, and whenever we work actively for them. So thank you so much, and apologies for exceeding the time.
Thank you, sir, for giving a detailed presentation about the costing of the medicines. And now it's the question time. I received some 4 questions from the audience. Actually, I will read out the first question. If in the calculation of RX cost per month with heart failure and all the indications, whatever you mentioned, was this at maximum dosages of all the medicines? And I wonder actually if she visit at any times to do with starting MGIMS in 1969, they have mentioned actually. So
Yeah, so to answer the question, well, the dose of aspirins was 75 milligrams, clopidogrel 150 milligram, atorvastatin 20 milligrams, metformin 500 milligram TDS, glimepiride 1 tablet twice a day, atorvastatin 20 milligrams. So are standard doses. They are not the highest doses, but they are the median doses. They are the standard doses that we use in practice.
the next question is, how do you wish to promote and share this low-cost approach among medical students across the nation?
Yeah, they need to be educated, because what happens is that we teach them very dry pharmacology, isn't it? We bombard them with classifications, with systems, and which they memorize and regurgitate in the examination. And the trouble is that in the third year and fourth year in the pharmacology, they learn generic names, non-proprietary. But as soon as they become interns, and they start writing brand names. So the half-life of that pharmacological knowledge is barely few months there. So we need to train them. We need to teach them that there's something called economics of healthcare as well. And what is a concept of an affordability. So in our hospital, what we did is that we introduced our hospital information system. And as our residents would start entering the drug, the price of that drug would also come. So then they became very cost conscious here, that, oh, the amlodipine is costing this much, so a monthly cost would come something like this. And gradually, and there are a few role models in Sevagram also who help them spread this evidence-based medicine and rational pharmacology and doing away with irrational things. So we need to pick up our residents and our interns and our medical students very early in their career to shatter these myths and to keep them away from big pharma.
Since the time is short, I will read two more questions. Why do pharma representative and pharma sponsored academic activity banned in at least government medical colleges?
Say it again.
Pharma representative and pharma sponsored activity banned in government medical colleges.
It's obvious, isn't it? There are huge commercial conflicts of interest here, isn't it? And if you don't want to keep it single, for example, in Sevagram, we don't serve alcohol. We don't have banquets. We don't have a 5-star accommodation. So we don't have those musical nights here. So we keep it absolutely simple. And if you keep it very simple, then, for example, this conference, we should be able to do these academic activities. But when people in other government medical colleges and corporate hospitals and corporate and for-profit organizations organize medical colleges, often the motive is not academics, the motive is something else.
Next is, how do you calculate the selling price? How do you incorporate the storage costs, salaries, electricity, etc. into that one?
See, partly we are funded by central government and state government. So partly we write off, or partly we subsidize this cost. But even in our budget of 240 crores per year, if we are able to take care of about 800,000 outpatients and about 50,000 inpatients, and 250,000 people fill their prescriptions for our pharmacy, is a proof that any organization worth its name should be able to dispense affordable drugs there.
The last one, actually, a lot of hospitals depend on pharmacy income for running the hospital. Is it possible for a hospital to be weaned off this practice?
Sorry, I couldn't get it.
A lot of hospitals are dependent on the pharmacy income for running the hospital. So if you're going to subsidize the rate, actually, how can they sustain in the industry?
I think Ravi would be the best person to answer this question, because I'm not an economist. Total budget, including medical, college and hospital both. 70% goes to salary.
So I did some analysis of the Sevagram with Ulas, and we found that it is a fairly economically run institution, and so their per bed cost is much lower to a similar comparable in the private sector. So the difference was something like 30 to 40% less per bed is spent on in the Sevagram hospital.
In fact, the first question which my residents often ask in the OPD, will this patient be able to afford? So that cost consciousness is something which has been built up in the mind, and this helps a great deal in choosing drugs, prescribing drugs, limiting irrational prescriptions, and so on.
One more question. What's the role of rational drug therapy in MGIMS?
I think this is rational drug therapy. So I agree that there are some irrational prescriptions here and there, but you cannot change the world, isn't it? So
Thank you for answering the questions. And
I would like to invite Mr. Rennie Charles to give a memento to Dr. S.P. Kalantri.